So hey friends, welcome you all to Sail to MDS Dental Academy. I am Dr. Malay Trivedi, pediatric dentist and assistant professor in College of Dental Sciences. So aspirants, today we are here with one more YouTube premier lecture on traumatic injuries to the teeth. It is one of the important topic for your endodontics and pedodontics perspective, because in exam it is obvious that 2 to 3 questions are going to come from this trauma chapter, either in the form of case-based scenario or they may ask you the multiple choice question. So please take care while studying this and try to hear each and every point. So this picture what depicts? It depicts that trauma can be at anywhere. Fine, so we should be ready with all the traumatic measures when you are doing your practice also, and the features and treatment plans should be ready in our mind. Fine aspirants, so let's talk about the injuries to primary teeth and injuries to permanent teeth. So first of all, we'll talk about traumatic injuries to primary teeth. So first of all, let's know the epidemiological trends commonly asked question in the examination. So what's the frequency of trauma in primary teeth? It is around 4 to 36%. What is the peak age? It's 1 to 2 years of age. So why we see around 1 to 2 years of age? Because it is this age where the child start crawling, their motor control will be there, and because of lack of neuromuscular stability, they may undergo trauma. The boys are found more frequently around 18.4% and girls around 13.4%. If you check the ratio, it is 1.5:1. The commonly affecting teeth are your maxillary primary incisors, and if overjet is more than 4 mm, they have the risk of intrusion. So these are few epidemiological trends. Now, what type of injury we can see in primary dentition? Most commonly we can see displacement injury. In that 74% is luxation type of injury. 6.5% we can see coronal fracture, and very rarely in primary teeth we can see root fracture, around 1.5%. Then if there is a primary tooth trauma, what it can affect to the permanent tooth? Because primary tooth and permanent tooth are closely associated with each other. So please try to remember this sequelae. There is one shortcut has been made, that is HOD is said. So H stands for hypoplasia, O stands for odontome, it can convert into complex or compound odontoma, D stands for dilaceration of crown, then S stands for sequestration of permanent tooth gum. Then if the trauma is so much, it can make your developing tooth angulated. There can be angulation of root, there can be angulation in lateral direction, or sometimes the arrest of tooth or root formation can occur. And the D stand for is disturbance in eruption. And sometimes you can see bifid root also. So please remember the permanent tooth sequelae from your primary teeth trauma. Now we'll see few pics. So what this indicates, this is the enamel hypoplasia, which is also known as Turner's tooth. And here you can see the root angulation because of trauma. So let's see the review, that how you will treat the different aspects of your primary teeth injuries. So when there is an uncomplicated crown fracture, what the uncomplicated means, that it is not involving your pulp, then you have to go for the enameloplasty or you can go for restoration. If there is complicated crown fracture in primary teeth, it means the fracture has involved the pulp, then you have to go for the pulpectomy. Either you can obturate with the help of ZOE or your calcium hydroxide iodoform combination or endoflask. And if the root status is not proper, you have to go for the extraction. Now aspirants, please notice this point. When there is crown root fracture, the extraction of primary teeth is needed. When there is root fracture only, you can remove the coronal necrotic fragments and go for the post and crown in your primary teeth. Remember, in primary teeth also we give post as well as crown. Then if there is concussion is there, if there is any soft tissue injury is there, just go for the occlusal relief and analgesic. If there is displacement injury like subluxation, go for soft diet, follow up. If the symptoms become worsen, like the patient is having pain or periapic lesion, go for the extraction. If there is extrusive luxation, the only option in the primary teeth is extraction. You cannot go for the proper placement, or we can say the proper repositioning of the teeth, because if you go for repositioning of teeth, the tooth may turn into ankylose, and that will hamper your permanent tooth eruption. And if there is intrusive luxation, then you have to check. If there is palatal displacement, then the choice of treatment is extraction. But if there is buccal displacement, you have to follow up, because in primary teeth there are chances that a spontaneous re-eruption can occur. So as per remember, if there is palatal displacement, you have to go for extraction, because your permanent tooth gum is located palatally to your primary teeth. But if buccal displacement is there, no problem, it can go for the spontaneous re-eruption. Now aspirants, if there is avulsion in primary teeth, what is the treatment option? No treatment is required. Okay, you cannot go for reimplantation of primary teeth. Fine. And even no space maintenance is required if the children is between 5 to 7 years of age. But if the children is around 2 to 4 years of age, you have to give the appliance known as Gropper appliance. You can check this space maintainer detail by clicking I button above. I have uploaded the video on that. Fine. So why we used to give space maintainer in the anterior teeth to children? Because of two things: aesthetics and phonetics. Now we'll talk about the junk of the trauma, that is injuries to permanent teeth. So let's talk about first Aiims class 1. What we can see here, only enamel fracture. Fine. So if there is small enamel infarction, you can seal it with adhesive system. Any roughened edges there, you have to smoothen. The choice of material here is the composite restoration. So you can see this is your simple enamel fracture which has been restored with the composite. Now if there is Aiims class 2 fracture, it means what? Your dentin is exposed. So you have to give some protective layering. So there are three choice of material. There is a calcium hydroxide, your glass, ionomer cement, and dentin bonding agent followed by composite. The ideal they have considered is the dentin bonding agent followed by composite. The success rate is higher in this. So in exam, if they ask a sequence based question, please first follow your composite, then GIC, and come the calcium hydroxide. Nowadays, if such Aiims class 2 fracture is there and you have the fragment, then you can go for the procedure known as fragment reattachment. Okay. So if they ask you which is the ideal treatment if fragment is available for the Aiims class 2 fracture, don't write composite restoration. Here it will come, if fragment is available, you can go for the fragment reattachment. So now experience Aiims class 3. You know, it's a big villain here, because here the pulp is exposed. It is your complicated type of fracture. So what are the treatment of choice? So the ideal treatment based on the duration and the size of exposure. If the duration is less than 24 hours and the size of exposure around 0.5 mm, you can see in this diagram, then you can go for the direct pulp capping. So the material for choice for direct pulp capping is your calcium hydroxide, glass ionomer cement, your dentin bonding agent, biodentin, and MTA. So the material of choice here is your biodentin and MTA. They have more success, followed by your calcium hydroxide, GIC, and dentin bonding agent along with composite. So in Aiims class 3, if the exposure is small and the trauma time is less than 24 hours, you can go for the direct pulp capping. But if it is more than 24 hours, exposure is large, then based on the root condition, you can go for the apexification, or you can say root canal therapy. Now let's talk about Aiims class 3 fracture for the immature tooth. Now imagine the immature tooth means what? The apex is open. So you have a two choice. So what is your goal here? If apex is open, your goal is that apex should be completed. Fine. So you can go for either partial pulpotomy, that is shaved pulpotomy, or you can go for this cervical pulpotomy. So why we do this pulpotomy experience? For the purpose of apexogenesis. We want the physiological closure of the root. So in case of immature tooth, you can go for the pulpotomy. Now let's talk about crown root fractures. So as we have seen that in primary tooth, the crown root fractures are seen very rarely, but in permanent tooth it is seen because of the strength of your alveolar bone. So let's see what are the type of crown root fracture. So if we classify based on number, it can be a simple, multiple. Based on location, it can be a cervical, middle, and apical. Remember, if there is apical root fracture, the prognosis is very good, no treatment required. Middle root fracture, the prognosis is fair, and cervical, the prognosis is very poor. In middle root fracture, the treatment, you can go for the root canal therapy, or you can go for the apical and coronal fragment restabilization. Then cervical fracture, the treatment of choice is extraction only. Now based on coronal fragment position, also you can classify like not displaced and displaced, and extent, sometimes partial root fracture is there or sometimes total root fracture is there. So please aspirants note this classification. So now we'll talk about root fractures. They form around 7% of your trauma to permanent teeth. So what the treatment is that you can go for the immediate reduction and complete immobilization before 24 to 72 hours. Remember aspirants, very important point, that pulp survival in root fracture is more compared to your displacement or luxation injury. The two important causes are that revascularization from PDL and decreased pulpal edema. So you can see in this diagram, this is the example for your middle root fracture. So these are the fractures you can say it's a middle root fracture. You can go for the splinting. After a few days, you can see healing there. And after that, you can go for the root canal therapy in that coronal segment. Sometimes the resorption of the apicus segment can also occur, or you can say the proper closure or a calcific barrier can also be formed. Then if there is concussion and subluxation, go for a soft light and observation. If mobility is more than 2 mm, then only you have to go for splinting, that also for 7 to 10 days. Now if there is a lateral luxation, now you can see in this diagram, the lateral luxation is that you have to go for repositioning and semi-rigid splinting for a period of 1 to 2 weeks. If there is extrusive luxation, you can go for the repositioning and semi-rigid splint for 1 to 2 weeks. So aspirants, remember, if there is any kind of displacement injury in permanent teeth, you have to go for the repositioning and you have to splint them with the kind of semi-rigid splint. You cannot give rigid splint to patient having luxation injury. If rigid splint you give, what will happen? Ankylosis can happen. So you have to give semi-rigid splint for a period of 1 to 2 weeks. If there is intrusion, aspirant, it is very important classification. Please remember, if intrusion is less than 3 mm, no need to do anything. The passive repositioning can occur. If intrusion is between 3 to 6 mm, you require to reposition with the help of orthodontic treatment. And if intrusion is more than 6 mm, the surgical repositioning and splinting is required. So please go through with this classification. Now what happened if there is avulsion? Okay, tooth has been completely out of socket, which is also known as X-articulation of tooth. Then you have to focus on these 5 factors. That is management at the site of injury. You have to take care of the soft tissue. Then you have to immediately put the tooth in the transport media, depending the media available with you. Then you have to manage in dental office. Either you have to check what is the root status is there, what is the socket status is there, how much time has been evolved. Then along with that, you have to go for the adjunctive drug therapy, that is systemic antibiotics are required, and then the restoration of the avulsed tooth. So what you have to do at the site of injury, if tooth is available, replant immediately if possible. If contaminated, you have to rinse it, and sometimes when you cannot reimplant, if there is a clot in the socket or like that, then you have to place the tooth in best transport available media. Now what are the transport media available? So aspirants, remember in exam, if they ask you save a tooth media, that is the example of your HBSS, that is a Hanks balanced salt solution. It is the best available solution right now. But the recent study have been done, which is done by the Gopi Krishnan, and they are telling that the tender coconut water is the ideal and best transport media. Fine. Then let's talk about few other media. Wire span, they can store a tooth till 12 hours. Then we have egg white. You can put your tooth in the ORS solution also. Then we have Eagle's medium, propolis. You can put in the toned milk. So for example, now some trauma is there and the patient has called you. So what the best available medium in home? That is the milk. But milk should be of which type? It should be toned type of milk. So, and it should be cold around -4 degrees Celsius. Sometime if milk is not available, you can store the tooth in the saliva, that is buccal vestibule. Even you can store in contact lens solution. The saline and water, they are the least favorable medium. If nothing is available, you can store in them. But the best available medium available right now is HBSS. Recently they have told is standard coconut water. Even you go for the wire span. Fine. And this image based question, please try to remember aspirant. So aspirants, now we'll talk about splinting. So what is splinting? It's the stabilization of tooth. But remember, in physiological manner. If you go for the rigid splinting, it will disobey the rule of physiology and they can cause ankylosis or further trauma to the teeth. So there are different types of splinting, but let us talk first about the rules of splinting. So imagine if there is a trauma in your central incisor. You have to take the support of the adjacent teeth. The one sound tooth should be there around the trauma tooth. Then only you can do the splinting. Fine. Why you require a sound tooth? Because they become one unit and they will absorb all the forces acting on them. So we have different type of splinting. The ideal splint in exam is your TTS, that is titanium trauma splint, and the suture or the sling, we can say, splint is the last resort. Okay, this is the last resort we do whenever we don't have the adjacent supporting tooth. So let's say one by one. So first is your composite and wire splinting. So we can see this is your composite and wire splinting. Then we have ortho bracket with passive wire. Aspirant, the word passive wire is very important. It should not cause any force. The wire should be passive. Then we have the resin kind of splint, where we use just a composite resin over the surface to stabilize them. Then we have fiber splint. You can see the example. We have three kind of fibers. We have a glass fibers, polyethylene fibers, and Kevlar type of fibers. Then, as I have told, that the suture or the sling type of splinting is considered as last resort. The minimum period for maintaining the splint is around 7 to 10 days. Now, as I have told you, the ideal splint is your titanium trauma splint. So aspirant, it looks like this. The example, they can ask you which is this splint. So please note with the diagram. Remember, the circumferential wiring is contraindicated in splinting because they cause more trauma to the soft tissue, as well as they can harm even your developing permanent tooth. So circumferential wiring is a contraindicated in tooth splinting. It is required whenever there is the bone fracture or like that. So aspirants, there are a lot of books has been there where they are giving these splinting guidelines. Like for example, if there is avulsion injury, how many weeks we have to go for splint and which type of splint should be there. So aspirant, this is the latest guideline from the IIDT. Please follow this for your Aiims and Neet exam, because in exam they are going to follow this only. Okay. So aspirants, if there is subluxation injury, the splinting time is 2 weeks. Extrusive luxation, the splinting time is 2 weeks. If there is a lateral luxation, intrusion is there, root fracture is there, the splinting time increases. That is around 1 month. That is 4 weeks. If there is a root fracture of cervical 1/3 kind, the splinting is around 4 months. It is the highest period for splinting. If there is avulsion, the splinting time is 2 weeks. If the avulsion is there and the condition is very bad, like dry time is more than 60 minutes, the splinting time will increase. That is around 4 weeks. For alveolar fracture, the splinting is 4 weeks. And as please remember, nowadays we always go for the flexible or semi-rigid kind of splinting. So please note this recommendation for splinting time and various type of injuries. Now aspirants, after splinting, what all the instructions you have to give to patient? This can be your case-based question, or we can say the extended matching question. So remember, no biting on splinted teeth, soft diet, and maintenance of good oral hygiene. Now there is one protocol we have to follow when avulsion happens. So there is different protocol for the open apex and close apex. Now imagine that if the patient is undergo trauma and immediately you have the teeth. So what you can do, you can go for the reimplantation. Fine. And you can check your reimplantation with your radiograph. After that, you have to place the flexible splint, systematic antibiotics, and follow for 7 to 10 days. And if the patient has not taken tetanus vaccine, advise for anti-tetanus if required. Fine. Then you can assess later on for the apexification, apexogenesis, and root canal therapy. Now, experience, remember, if the tooth is available immediately, you can reimplant. But if the extraoral time is more, like between 15 minutes to 6 hours or 15 minutes to 120 minutes, then what you have to do? Imagine aspirants, if the extraoral time is between 15 minutes to 6 hours, okay, you can store them in milk or HBSS. After that, you have to soak them in 1% doxycycline. Why doxycycline? To restore the PDL fibers. Fine aspirant, if the time is between 15 minutes to 120 minutes wet, but it is, we can say, kept in non-physiological media like water or saliva, then you have to place them in HBSS or the best available medium. After that aspirants, you can go for the reimplantation, splinting along with the post-operative care. The same thing happens if the extraoral time is between 0 to 16 minutes and there is a dry storage, means the patient parent have not stored the tooth. Okay. Now imagine the extraoral time is more than 60 minutes and the tooth has been kept dry. Then what you have to do? Then the HPSS will not come into picture. Then you have to soak them in citric acid. Fine. For 3 minutes, then you have to remove all the debris. After that, you have to place them in sodium fluoride solution. Why sodium fluoride solution? To make the root resistant for the resorption. Because normally we can see reimplant resorption in such avulsed tooth. Then when you go for follow-up of such open apex teeth after 7 to 10 days, you have to assess them whether they require apexification, apexogenesis, or sometime if the apex is close or near close, you can go for the root canal therapy also. So friend, please remember, if there is open apex and if time factor is very important, and also how the condition of teeth, whether it is a dry or a wet. Okay, so if time is less, you have to use doxycycline and your HBSS. If time is more, then you have to use citric acid and sodium fluoride. Remember, doxycycline is for regeneration of your PDL fibers and sodium fluoride is to avoid replacement or reimplantation resorption. Now what happened if the tooth has closed up? So you can reimplant immediately at the site of incident, or if extraoral storage time is around 15 to 6 hours but in physiological media like HBSS or milk, then you can go for reimplantation. If the time is 15 to 120 minute wet but in non-physiological media, or if there is a 60 minute around dry storage, then you have to keep it in the physiological media like HBSS, and then you can go for your reimplantation. But if extraoral time is more than 60 minutes and it is also dry type, then you have to soak them in citric acid for 3 minutes, then you have to place them in sodium fluoride for 20 minutes, then you can go for your reimplantation. Remember aspirants, we keep doxycycline for 1 minute, citric acid for 3 minutes and sodium fluoride for 20 minutes. This is also an MCQ question. And remember, at the end we require a root canal therapy in closed apex. So whenever you go for reimplantation of avulsed tooth in permanent teeth and apex is closed, the ultimate treatment is your root canal therapy. If the apex is closed, but if the apex is open, you can go for the apexogenesis, apexification, and also revascularization, that is a regenerative endodontics. Now aspirants, I have not talked about classification in the beginning because I want to show you this picture, because all students make mistake in classification. So simplified manner I have put. So at least class 1 you can see enamel fracture, class 2 this yellow part, that's the dentin is involved, class 3 your pulp is involved. What's a class 4? It's your non-vital tooth. You can see your periapical lesion. Class 5 is your avulsion. Class 6 is your crown fracture. Class 7 is your luxation kind of injury. Class 8 is your fracture and masses of crown. And class 9 is the fracture of your deciduous teeth. So aspirants, that was all for trauma. If any doubt is there, any confusion, you can contact me. My information is there in the description box. And thank you all for your patient hearing, and see you soon with another lecture. Till then, please aspirants, work hard. Now very less time is left for the examination. Follow proper planning and follow our pyramid of preparation. That is going to help you during your revision phase. Thank you all.